Good afternoon, everyone. I'm Dr. Kurt Armstrong, and welcome. Today we're going to talk about a topic that's very, very important to me. It actually was inspired by my patients, inspired by a few podcasts that I listened to recently. And this is my first time talking about this in a lecture format, so bear with me if I'm kind of halting with it. I just want to make sure that I get to all of the information that I have for you guys. Before I get started, I just want to do a real quick kind of, sort of public service announcement. So we're starting to see an increase in COVID cases. So I just want everyone out there to be aware of that. Mask when appropriate, socially distance when appropriate. If you haven't been vaccinated, it's a good time to think about that. If you have been vaccinated and you're due for a booster, contact your local pharmacy and see if you can get that done. The most important thing is make sure that you have a plan with your provider in case you do get sick. We always recommend at Newport Family Medicine that people own a pulse oximeter, which is a small device that you can put on your finger. It's not very expensive. It tells you your oxygen level in your blood if you do test positive. It gives you an objective number to look at. The other thing is there's a medication out there called Paxlovid now, which is widely available. And so if you get sick, make sure you contact your provider. So enough of that. Let's move on to our topic today. So probably many of you will identify with this, but essentially we're going to talk about, do I really need all these medications? Tapping into the subtle art of deprescribing as we get older. As I said, I'm Dr. Kurt Armstrong. I'm from Newport Family Medicine. I'm a Hoag Physician Partner. And today, formally, I gave a talk called Rocking into Our 70s and Beyond. And this is sort of a drill down on some of the things that we can be doing to make sure that we guarantee those things. The information mostly comes from UpToDate, which is a website that most doctors use, and another organization called the American Academy of Family Physicians. And let's get started. So first, just a little bit about me. So as I said, Dr. Kurt Armstrong. I'm originally from San Diego, but moved up here in high school, and I graduated from Laguna Beach High School. I moved up to Montana, went to the University of Montana and got my degree in biology, and then I moved out to Ireland and went to the Trinity College, Dublin. And that picture there is actually a picture of our library at Trinity, which was a fascinating library to be able to go to. I came back to the United States, did my residency here in Orange County, and have been with Newport Family Medicine here at Hoag for the last 12 years. And then just to recap, so on my previous lecture, and those of you that know me, if you're listening to this, or that are already my patients, you know that I kind of talk a lot about the things that we can be doing, the sort of the bedrock, the foundation to our health. And mostly what that is lifestyle things. And I always kind of focus it around this concept of blue zones, which some of you probably have heard of. But essentially, blue zones are places throughout the world where people routinely live into their 90s very healthily and hit that 100-year-old mark at a much higher rate than the rest of the world. The original 5 were these 5: Okinawa, Japan, Sardinia, Italy, Icaria, Greece, Nicoya, Costa Rica, and then here in Southern California, Loma Linda. And then I always like to talk about it that with my patients, I want us to create a blue zone in our own life. So there's no reason why we can't just live in our own little blue zone bubble and benefit from all of those things. In Japan, they always talk about this thing called ikigai, which means it's a word that means living with purpose. In Italy and Greece, we all know about the Mediterranean diet. In Costa Rica, they're very, very well known for their active lifestyle. And in Loma Linda, again, vegetarian, mostly in that community. It's a community of Seventh-day Adventists, and have a deep sense of community and also purpose. So from that talk, and then we'll pivot into this talk, I just want to reiterate the things that I always talk to people about. And so these are the 5 principles. And I always, if you see me as a patient, I talk about this all the time, but essentially 5 things. Maintain a normal body weight. Exercise on most days. No tobacco, and if you do smoke, please quit now, and we can help you with that. Alcohol, but only in moderation. And then my favorite is the manage stress and live with purpose. Today's topic is designed to make sure that none of our medical treatments or how we're sort of interacting with the medical world are interfering with any of these principles, these goals that we try to get to. All right. So first, let's kind of define this problem. So, in this country, about 50% of people, you can see on the slide here, have 5 or more, these are seniors, have 5 or more medications prescribed to them. And then if you have a history of cancer, you see that number goes way up to 84%. So that's a lot of medications, and that's at least 5, so 5 or more. And then 20%, 1 in 5 people have 5 or more medical conditions that do tend to require medications. These numbers are higher than what we see in other Western developed countries. So in Europe, the number of patients on 5 or more medications is only about 20%. And there's questions on why that is and what the issue with this is. The definition is a little bit wide here, though. So I try to reiterate, and I'll talk about it more as we go through all of this material, that we're not talking here about medications that we should be on. We're talking about inappropriate medications. So medications that maybe aren't needed any longer, and they can lead to different issues. And below, I describe them here. So increased risk for adverse drug reactions. So that's having a overdose of a medication. It's having a side effect to a medication. The one that I find to be the most interesting here is this thing called prescribing cascade. So when folks are on a lot of medications, what ends up happening, the prescribing cascade, is that side effects get misinterpreted as new medical problems, and therefore new medications are prescribed to treat the side effects of other medications, and that's what's referred to as the prescribing cascade. And you can imagine that gets complicated pretty quickly. Being on all these medications is an independent risk factor for people falling, and that has a whole set of things that go into that we're going to get into a little bit later here. And then this is an interesting one. So when we're prescribed a lot of medications, it's less likely that we're going to adhere to the medication regimen that we're supposed to be on. So that can interfere with our ability to treat these medical problems that we are all having. In this country, we're really good at starting medications, but we're less good at stopping medications. So we want to make sure that we're having a plan on how to stop medications. The other thing that we have is direct-to-consumer advertising. So there is a little bit of a push for people to feel like they need to be taking medications because they're seeing that on television, and that might play a role with this issue as well. And I want to say before I go on that there's a live chat, so you guys can submit questions at any time. And if you submit them, they'll hand them to me, and then we can address them as we go along. Next, we want to go on to just the solution. So deprescribing. So this is the concept of looking at people's medications and deciding what is and is not needed. The concept really is that deprescribing is an essential part of good prescribing. And people always, how many times when you go into the hospital, you come home from the hospital, we ask you every single time, what are you taking? Are you taking this medication? Are you taking that medication? And we're always trying to reconcile those medication lists. And a lot of it is that we need the accuracy on what is going on there. The other thing is just that medication, how appropriate are they? So we should always be having an ongoing review of your medications and asking the question, do we need this? Is it an appropriate medication? Is it doing what we intend it to do, or is it causing an issue? And that's where that medication reconciliation comes through. These days, things are a bit better in terms of how much data is shared between the outpatient clinics, the hospital, the skilled nursing facilities. The advent of electronic medical records has been really important in getting some of these things looked at better. I wrote up there Beer's criteria. That sounds like a lot of fun, but it's actually just an expert consensus on medications that was created in 1991, and it really highlights medications that are problematic as we get older. So they're medications to be avoided in seniors if we can. The STOP criteria, and there's another one called the START criteria. That's the screening tool of older person's prescriptions, and then the START is the screening tool to alert to right treatment. The idea there is that we're creating a tool that physicians and patients can use together to identify if there's medications that we need to be stopping for you or thinking about stopping. Medicare has these 4 Ds that they put out there, and this is where they find problems. And about 20% of patients that are Medicare recipients actually have one of these, and it's either an inappropriate dose, inappropriate duration. Not all medications are meant to be taken forever. Duplication of medications, so being on essentially the same medication, it might be the same class of medication, it might be doing the exact same thing, but duplication of medications. And then the last one, drug-drug interactions. Again, with our electronic health records, that helps us a lot in identifying those drug-drug interactions. But it's still a problem that we need to try to find better solutions for. Okay, so who are we really trying to help here? So those that are considered polypharmacy, so those are the patients that are on 5 or more medications, and they might be on inappropriate medications. They are about 6 to 12 times more likely to have adverse medication reactions or drug reactions than people that are not on those medications. Same thing with multiple morbidity. That just means that we have a lot of medical problems. The problem with that is that it usually does mean that we're on a lot of different medications. The renal impairment, for anyone that has decreased kidney function, there are adjustments of dosing for a lot of people that we want to make sure that we're getting right. Multiple prescribers. So if we go into the hospital and then we go into the skilled nursing facility, we end up having multiple different care teams that will be prescribing medications, and it's really important that those transitions from one setting to the next keep in mind what medications we should be continuing, which medications we should be stopping. We're also trying to help those as they get older. Medications have a stronger effect as we get older. Frailty and dementia. So a lot of medications do interfere with our ability or our cognitive function rather. And if we're already struggling with that, then it's really important that we get you off of some of those medications. And then the last one is an interesting one, so limited life expectancy. Here is a little bit different. So some things, if we have a limited life expectancy in front of us, there are some things that we don't need to be aggressively treating people, and there are some things that we can relax on. So we talk a lot about opioids, which are narcotics, and the dangers of those, and there's another class of medications that we're going to talk about too called benzodiazepines. Sometimes, if our life expectancy is limited, we're not as needing to limit those, but we also may not need the high doses for our blood pressure, for cholesterol, things like that. So these are all people that we want to look at and think about as we're looking at the number of medications we're on and trying to optimize that or streamline it. Okay, so the goals of prescribing. Or de-prescribing, I should say. So like I said, optimizing medical care. So we want to make sure that we are doing what's right for you and not just leaving you on medications because somebody else prescribed it. Reducing adverse drug reactions. The less medications we're on, the less likely it is that we're going to have an adverse drug reaction and a drug-drug interaction. So we want to really try to avoid those sorts of things. And like I said, people that are, don't have, so many medications they're on, it's a clearer plan for them, so they tend to have better medication adherence. And then this is the most important thing that I'm talking about here. So this is not a withdrawing of care or giving up, but it's a streamlining of your care and optimizing your medications. And lots of patients talk to me all the time about what medications they can be on, what medications they can get off. So it's definitely a worthy discussion to have with your doctor. De-prescribing is not something that we want to just do at home. So it actually is pretty complex, and it requires that sort of communication between you and your physician to decide what our priorities are and what our goals are on how we're going to reduce the medications that somebody is taking. Generally, there's 3 phases to that. So the first phase is really just kind of getting that accurate list, understanding what we're taking, when we're taking it, and how we're taking it. That can be easier said than done when there's lots of medications, or if you have a caregiver or a family member that is organizing your medications for you, and sometimes they're not available during our visits. So then it's difficult to determine what we're actually taking. So that phase one is the defining of the issue. Phase two is really where we sit down and we look at your medical problems and we look at your medications. And what we're looking for is valid indications for you to be on those medications. And so if somebody has hypertension, high blood pressure, it's definitely valid that they're on an antihypertensive medication. So that's an obvious one. But sometimes, and this happens quite frequently, somebody will come into the office, they're a new patient, and I go through their medication list with them. And I stop and I say, oh, what are you taking this for? And sometimes the answer is, I don't know. And somebody must have prescribed it for me once. And then I look at who the prescribing physician is. I go, who's this physician? I don't know. And somehow that medication just persisted there. So if we can't figure out what the valid indication for it is, probably not needed. And it's good to stop those things. So what to reduce and eliminate. So, and it's not always about stopping the medication. So that next point there is that tapering versus stopping. Sometimes we're just being overtreated with medications and we want to streamline that and lower the amount of medication you're taking. And sometimes things just do need to be stopped. And not everything can just be stopped overnight, so we do need to create a plan for that. And that's actually phase three. So phase three is the plan for how to stop everything, and then implementing that plan and monitoring. So if it's blood pressure and we feel like we're over-treating your blood pressure, you're getting lightheaded, you're at risk for fall, all of those sorts of things, and we lower your medications, then we need to have you back and see what your blood pressure is and make sure that we're controlling the risk factor that we want to control without giving you all of the unnecessary problems that go into being being over-prescribed. And this might take time. So it's a systematic and proactive approach to looking at our medications and deciding what to do here. So it might not happen in one visit. It might take multiple visits. It may not be appropriate to stop multiple medications or decrease the doses of multiple medications during one visit. So you could see that there might be a linear approach to this, that, hey, today we're going to do this. At your next visit, we're going to think about doing this. There's a couple mantras that have always been spoken when it comes to prescribing in people as they get older. And one of them is to start low and go slow. And that just minimizes the amount of side effects that people could have. And then what we're really trying to achieve is the lowest effective dose. And that's really what the concept of DEPRESCRIBING is about. Okay, so what are we doing with these goals? So one is we're reducing medical burden, and what that really means is just the amount of medicalization that you're undergoing. A lot of people don't want to, be on multiple medications. They don't want to feel like they're, just in the doctor's office all the time. So if we can streamline things, we usually do reduce that burden. Interestingly, so this review here, so if it's 39% of people will, if we review your medications, about 40% of people, we can find things that we need to reduce or that we can reduce either the dose or eliminate the medication altogether. And if it's just looking at reducing the dose, that's about 60%. So that means that most people, when they come into the doctor, are on higher doses of medications than they need to be. And this data comes from Medicare, and so they've been kind of looking at this problem for a long time. Reduction of fall risk. So this one's a very important topic so when we're on multiple medications and we're dealing with side effects, and we talked a little bit about that prescribing cascade, we really run into all sorts of trouble where we're not optimizing a person's ability to walk, to engage in the activities at home of getting out of bed, getting dressed, taking care of ourselves in terms of hygiene, all of the things that we do at home, and so the studies have suggested that if we do a close, medication review and we eliminate some of these medications that are higher risk, that we can reduce that fall risk by about a quarter, and that's in nursing home residents. Now, a lot of people are, at home, and they're having caregivers come in, and they're still at risk for fall. And the data is less clear on what we do for those folks at home because it's harder to get that data. But it clearly would be reducing fall risk for those that are just living at home as well. So some of this, although we talk about the nursing home setting, it applies to really all settings. And obviously we're focusing in on these high-risk medications, in high-risk patients. So the people that we talked about before, and then the high-risk medications are really, things that interfere with our ability to react, interfere with our cognition. I mentioned opiates and benzodiazepines, which are like anti-anxiety type of medications. The other ones are sleeping pills, medications that have what we call anticholinergic side effects. And I'm going to actually go through kind of like a top 10 list of things that we want to, try to eliminate here. If we're at risk for falls, it goes back to those kind of 5 principles that we talked about before. Like, what are the 5 things that keep us healthy and make us have our own little personalized blue zone? Well, if we're at risk for fall, certainly number 2, which is exercising, is going to be, we're not able to engage in number 2. So we're going to miss out on the benefits of that principle. The other one I think that's important here too is, like, I always talk about alcohol in moderation. So obviously, if we're on medications that are affecting our central nervous system, that have effect on our cognition, alcohol is a hugely complicating factor in that point. So moderation, if not at all. And then, of course, just to go back to where this is an effort to optimize. So it's not just medications that reduce fall risk, but we want to make sure that if you need a walker or a cane, that you're utilizing that you have good footwear. If you have concurrent issues like osteoporosis, although we're talking about deprescribing here, that is an issue that might be where we need appropriate prescribing. So treating osteoporosis may be very, very important for reducing the consequences of fall, which would be hip fracture or other fractures that can occur when we fall. And then if these medications and being on this amount of medication is reducing or is increasing, I should say, our fall risk, I mean, you could just imagine it has impact on driving, and the safety that goes into that. So very important, that we're kind of focusing in on this. And then that kind of just kind of dovetails right into the cognitive function aspect of things. That's actually a chimpanzee's brain, by the way. So if you're thinking like, oh, my brain's so much bigger than that, it probably is. So we want to avoid the negative effect of these medications that make us drowsy. So it really is important that we kind of, talk about and think about discontinuing or reducing the doses of sleeping pills, benzodiazepines, and some of these other medications. By doing that, it's very, very clear that we improve the cognitive function, especially people that are living in a nursing home setting or that are requiring home health aides. Eliminating these medications really does increase cognitive function, which goes back to those 5 principles. It's hard to live with purpose, and it's hard to have a reflective life, if we're not able to think clearly. And I always kind of quote two people I quote. So Seneca, who is a Roman orator, and Cicero, who is also a Roman orator. So Cicero, wrote a dialogue to his young nephew called How to Grow Old. And it really was the principles of it really had to do with, like, if you want to have a intellectually active, as you get older, you have to be intellectually active now. So he just really, his point was that every day we have to be doing these things. And Seneca, the same thing. He felt that if you lived a distracted life, one where you weren't reflective or using your brain, that it was a fast life. So that in order to really enjoy and savor our lives, we really do need our cognitive function to be intact. I mean, anyone that's been on multiple medications, we'll talk about, brain fog, or this medication makes me feel drowsy, and it's really important that you come in and you talk to us about that so that we can help, remedy those sort of things. And then for the entire system, it reduces the risk of hospitalization and death for us to engage in this sort of review of your medications, and with an effort to reduce either the dose, the duration, drug interactions, but we want to reduce that risk of hospitalization. In the nursing home, it's very, very clear that both hospitalization and death are reduced when we do this. For people living at home, it really appears that it's mostly mortality that we're reducing, which I don't know about you, but I think that's pretty good. So if we can reduce mortality, that's a really kind of good thing. And these are big numbers too. Like for the reduction of hospitalization in those that are living in nursing home, it's over 1/3 reduced risk of hospitalization, and it's about the same for reduced risk of death. At home, it's about a 1 in 4, a 26% risk reduction for death just by streamlining our medications. It's really that simple. And of course, if it is that simple, what's the deal? Why haven't we been doing this? So we wanted to go through just like the top 10 medications that maybe are things that we want to look at and reduce. The first one on this list is benzodiazepines. That's medications like Xanax, Ativan, or lorazepam. Valium is an older version of it. Sometimes they're used as sleeping tablets like Restoril, which is temazepam, and sometimes they're just used as anxiety medications. But where they are probably the most problematic for people as they get older is if these medications are being used as behavior modifiers. So if they're being used because we're getting agitated, certainly somebody that has either psychiatric or dementia, if they have those sorts of issues, these medications can be very problematic in terms of fall risk and cognitive function. They can't just be stopped, though. So this is the benzodiazepines especially. If you're listening to this right now and you're going, you know what, I am taking that, and I feel like I'm feeling tired all the time and I'm not thinking straight. It's really important that you actually go in and work on this with your doctor, because it's not a cold turkey medication. Lots of these medications are not cold turkey medications, but this is one where people do get withdrawal symptoms, and that can even be life-threatening. But those symptoms are usually insomnia, anxiety, irritability, GI upset. So those often occur. And usually it's just by a small reduction even. So 25% of the original dose, reducing that much can cause those symptoms. So it's really important to slowly taper these medications with your provider. It usually takes about 2 weeks to do that. And there's a couple trials that have looked at this. There's one called Empower. There's another one called DEPRESCRIBE. And so there are clear guidelines, that you and your physician can follow to reduce the burden of those benzodiazepines. Proton pump inhibitors. So these are widely prescribed, and they are also available over the counter. So harder for us to know if you're taking them. And again, it goes back to the phase 1, the accuracy of our lists. If you're taking something over the counter, that is a medication, and it should be included in these medication lists. So when you're seeing your doctor, make sure that you bring up those medications. I highlight, proton pump inhibitors here, which, just so you know, it's omeprazole, which is available over the counter as Prilosec. There's also Protonix, Nexium. These are all medications that are available over the counter, and some of them get prescribed. The Protonix is a prescription medication. And some people absolutely need to be on them. So I always call out the certain group. So if you're listening to me now and you're saying, gee, I need to be off of this Nexium, the truth is that if you have a process called Barrett's esophagus, you really should be on this. If you have to take non-steroidal anti-inflammatory medications like ibuprofen, Aleve on a regular basis, and you've had issues with gastritis or bleeding in your tummy in the past, you definitely need to be on this as well. There are some interactions with these medications that usually we would not have you on one of these for, but some of the antiplatelet medications don't mix well with these. But it's always reasonable to consider other medications too. So not just deprescribing or lowering the dose, but considering an alternative. So there are alternatives to proton pump inhibitors. Unfortunately, they're also in a top 10 category that I'm going to discuss here in a second. But it's they might do better than the original. Proton pump inhibitors, the problem with them is there's a type of diarrhea that people get called C. diff colitis. It used to be more considered a in the hospital type of infection to get, but it's an overgrowth of a bacteria that causes an issue, releases a toxin, and then it causes chronic diarrhea, and sometimes it can be very, very difficult to treat. And proton pump inhibitors, if you're taking them regularly, puts you at an increased risk for developing that. Also, it's at an increased risk for hip fracture. So these work on calcium channels inside your body, and so they affect calcium metabolism, and they also affect vitamin B12 absorption. So those are all the things that couldn't go on with those. Neuroleptics, the other name for that is antipsychotic medications. There's quite a few of these. The most common one is quietapine or Seroquel, but there's a whole slew of them. There's a new one called Abilify that's getting used a lot. These are used primarily for like bipolar disorder. They can be used for sleep and kind of behavior issues with dementia. But the data on these neuroleptics is that in seniors, they're having an issue. We increase your mortality rate by putting you on these. So if it's not absolutely required, or there's another way to manage, either the anxiety component of things, the sleep component of things, or the behavior, if we're having dementia, then we would want to engage in those things. And there's a lot of non-medical intervention, non-medicine interventions, I should say, that can be utilized here. So focusing on those strategies is always good. Again, this is the type of medication that also is, as we're reducing the dose, it should be monitored with your doctor. Just back to the proton pump inhibitors as well, you can get like rebound symptoms. So if you stop it, all of a sudden your gastritis symptoms can recur, but that's usually a short-lived process. Okay, and then glucose-lowering medications. So anyone that has diabetes, is typically on some glucose-lowering medications, but there's a fine balance. And the big ones here are like insulin, so if you're on actual injectable insulin, or a class of medications called sulfonylureas, which is like glyburide and glipizide. These can lead to hypoglycemic events, and that's when their blood sugar gets so low that they're just not adequately feeding their tissues. So it's usually associated with pretty profound cognitive changes when it's happening, and it can be life-threatening. And it can be reversed, by putting some just glucose back in the person's body. But if somebody or if you have been experiencing recurrent hypoglycemic events where your blood sugar has gone too low, it is important to get the medications at the right dose for you, so that we're not creating that, but we're still not letting your sugars get too high that you're getting the downside or the downside of diabetes, which can affect your kidneys. It can affect your eyes and your vision. It can affect your nerve endings and your hands and your feet. So we want to strike that balance there. But if you're having those low sugars, that's important. And as we get older, that becomes more of a problem. And in fact, our goals for glucose control, they relax a little bit as we get older. So and primarily so that we're avoiding those low sugar events. That last one on there, so non-benzodiazepine sleep medication. That's Ambien, and it's relatives. Again, it's sedating, so it puts you at an increased risk for fall. There's a lot of question that goes into how is it really giving you healthy sleep? There's a whole discussion to be had on what the definition of insomnia is. And is it the number of hours we sleep? But usually those that suffer the most from insomnia are suffering because they're identifying themselves as having insomnia. So they're subjectively feeling that they're in need of more sleep. And sometimes there's other things going on that are preventing them from sleeping. Their thyroid may not be functioning correctly. They may have anemia. So there's a lot of things that could be masquerading as these issues that we're trying to solve. Okay, and then just carrying on with our list here. So anticholinergic, no one's ever heard of that, but it's a very, very common kind of type of side effect that medications have. There's a whole bunch of them. And so, I mentioned before for the proton pump inhibitors, we could back off of the omeprazole, but then, put you on, famotidine, which is Pepcid. But some of those antihistamine medications fall under this category. Certainly, you can see just a couple below is antihistamine. So they have kind of both of those effects, but they can be sedating, and that can put us at increased risk for fall, cognitive decline, those sorts of things. The other ones, and it's pretty wide list here, but incontinence medications generally are not prescribed in younger folks, but they have these side effects. What goes on with an anticholinergic side effect is we can have confusion. We can have urinary retention where we're just not able to urinate. We can be agitated. Our blood pressure can get low. We can get really severe dry mouth. So these are all issues that can go on and be long-term things that may be related to your medications. There's an antidepressant called paroxetine or Paxil that can do this. Cough medications have anticholinergic side effects. If you have COPD, there's a medication called Spiriva that has these types of effects. Seasickness tablets. So all of these things are important for us to identify and kind of make sure that we're pulling them out of your medication list if they're not appropriate to be there. Like I said, all of this stuff also has to do with appropriateness. That if you need to be on it, you need to be on it, and that's that risk-benefit analysis that we always come into with our medications. There is a question about these anticholinergic side effects. Is there a increased risk for development of Alzheimer's disease with anticholinergic medications? It's not exactly clear, but it does look like there is an increased risk. So again, long term, if we could avoid these. Sort of a subcategory on these anticholinergic ones, there's a thing called a cholinesterase inhibitor, which there's a medication we actually use for dementia called Namenda. So the question there is it making things worse? And then when you really tease out the data on Namenda, does it really have strong data? Should we be using it? So those are kind of bigger questions, about whether or not medications are effective. But this class of medications certainly has lots of issues. The antidepressants, amazing medications. So if you're experiencing depression, the medications really do a lot of good for people, and it's like on that list of the 5 principles, that kind of living with like a quality life or a life with meaning. I think when we're depressed or overly anxious, it's hard to kind of back up and see the wonderfulness of our life. And depression, unfortunately, kind of reaches into the future and rewrites things, and it reaches into the past and rewrites things. So a lot of people really should be on these. There are some side effects, though. So one is this, like this is a very common medication to be prescribed in that sort of prescribing cascade. So if we're on a bunch of things that are making us feel fatigued and they're making us feel irritated, and then all of a sudden we go, oh, gee, maybe you have depression, and we put you on this. So it's a common one that ends up, being one of the steps in that prescribing cascade. So we want to think about that, make sure that if we are feeling depressed, we're like kind of looking upstream and saying, well, what's going on here? Are we doing it? And I mentioned thyroid and anemia. Those are common masqueraders as a lot of these problems. But some people need to be on them. It also can lead to what's called hyponatremia. So in our blood, the sodium level drops. And that leads to confusion, disorientation. So there's and it can be life-threatening. So that's a potential side effect with these medications. And particularly, we talked about drug-drug interactions, and this kind of like leads right into these antihypertensive medications, the next one on the list. Some people are on a drug called Lasix and hydrochlorothiazide, and those medications can affect our sodium levels as well. And if we're on those, and we're on an antidepressant, you can see how complicated it can get. The blood pressure medications are extremely important. So one of the biggest risk factors that we can have from a cardiovascular, heart attacks, heart disease, stroke, is our blood pressure. So it's really important that we're checking our blood pressure. It's really important that we're treating our blood pressure. Obviously, the lifestyle stuff, very important. So salt reduction, alcohol reduction, making sure that we're exercising, maintaining a normal body weight, not smoking, and living with purpose are all of the things that do help with that. But sometimes we need to be on antihypertensive medications, and they're really important. There's usually a pretty defined stepwise way that we prescribe these medications. But sometimes we're overshooting our targets, and we'll have and things change as time goes on. So what was your medication regimen 10 years ago may not be a medication regimen that works for you today, because either your body mass has changed, the physiology inside your body has changed, you're on other medications that are now sort of acting in concert with these medications. So we always should be reviewing this. So if we're overshooting that, we might make your blood pressure drop too low. And we've all had that thing where we stand up and we sort of, kind of brown out, and then, kind of puts us at risk for a fall. So we want to avoid those sorts of things. Some medications do have like central nervous system effect. There's one called clonidine that gets used for blood pressure that can do that. If you're on either a beta blocker or clonidine, beta blockers are like metoprolol, atenolol, carvedilol. If you're on one of those medications, or clonidine, it really does need to be tapered. And there's this process called rebound hypertension, that we withdraw the medication, all of a sudden your blood pressure skyrockets. Of course, we want to avoid that. The antihistamines, I kind of touched on that already. They really are, they just suppress our central nervous system. If you have really bad allergies, if they're nasal, you can always, we could think about doing the Flonase, or some of the other medications. And some of them have less effect than the other ones. The Benadryls of the world are the ones that are usually the most sedating. And then opioids. Opioids is a whole hour-long discussion in itself. But those of you that are in pain, we need to be treating that pain. However, these medications have they have lots of side effects associated with them. So, and I apologize because I spelled opioids wrong on there. So for those of you that are English teachers out there, scold me. But I have it spelled right on here. And then the other thing is opioids really should never be used in conjunction. I'll go back with those benzodiazepines. So those are really medications that we really try to separate and avoid. And if you are taking those together, you may have been prescribed something called Narcan, which is a thing you can squirt up your nose that reverses the effect of opioids. And that is to help reduce the ongoing epidemic of opioid overdose in this country. So really important, but if you're having chronic pain, again, it's like there's a systematic, controlled approach to that. And we have wonderful pain management physicians here at Hoag, that really do help us get people, get all of these things under control. And it's not just medication, but it's physical therapy, it's injections, it's sometimes surgeries. So there's a lot of things that go into that. And before I move on, just on this top 10 list, and I want to make sure I give us some time for questions. On this top 10 list is a lot of you may be on statins. So there's a lot of, I think that there's just, because they're so widely prescribed, just a lot of people talk about statins all the time. They say, oh, I couldn't handle that. But statins are probably the most successful prescription medication that's ever been created in terms of how it manages cardiovascular disease, and really is the backbone of most cardiovascular disease treatment. There's probably data that suggests that treating people after the age of 75 with statins is appropriate and is beneficial to them. However, it may be at a lower intensity. There's a lot of goal setting that goes into whether or not people should discontinue statins, lower the doses of statins, things like that. Aspirin's the other one that we get asked a lot about. I didn't put it on the top 10 list, but it's, aspirin's one of those ones that we've had different guidelines over the years on who should be taking it and who should not be taking it. It's not a miracle drug. But for those that should be taking it, those with cardiovascular disease or that have had strokes, they should be taking it. But I usually just say only when indicated. And it kind of, it has a whole bunch of side effects itself in terms of, it can cause ulcers in the stomach. And so we want to just, make sure you're thinking, or we're all thinking about that one too. And aspirin's one of those ones, because it's over the counter, sometimes we won't know you're on it. So make sure that you know that. And then what kind of interferes with this whole process? Sometimes as patients and family members, we're reluctant. We might either be nervous that coming off of this is going to put us at a higher risk of the problems that go in with chronic medical conditions. Some of these medications, like the benzodiazepines and the opioids, there is a kind of a secondary benefit. They create a feeling of euphoria. They have addiction potential and things like that. So there's reluctance to come off of something like that, but it's worth talking about. And Medicare has put out data that just about 90% of all older adults are on board with reducing the dose or eliminating at least one or two medications from their medication list. So I think it's a good kind of thing to talk about. As I've kind of been talking, I've been sort of talking about studies and things like that. So there is probably not enough data on this topic that's really, really strong and says everyone should be doing this and that kind of thing. But there is more objective data that's coming along. Some of these things are easier, like your blood pressure, if it's going low or your blood sugar is going low, that's an objective measurement where we can say, yeah, we definitely need to start deprescribing here. But other things, there's just it's not as clear. But so that's a little bit of a barrier, I think. Limited time. So this is, I think, probably the most important barrier. So it's just kind of. If you walk in with, 5-6 medical problems plus, it just, you can see how, and that's why I'm encouraging people that, we try to reconcile these medications at every visit. And if we're trying to lower your doses, we really need that follow-up. We need to create follow-up for you so we can kind of create the time to be able to do this appropriately. The care shared amongst multiple providers. So this is a complex issue. So lots of people have had that experience. They went from home to the hospital, to the skilled nursing facility, and then heaven forbid something goes wrong, you go back to the hospital, and then back to the skilled nursing facility, and then eventually end up at home. And all along, different people are taking over the care and prescribing medications, and then by the time, or different settings use different pharmacies, and they didn't have the medication that you normally are on, and they put you on something different. So that's a big barrier to our being able to kind of get the overview of all of this. Recognizing the problem, I think, is getting better and better. These electronic health records. Here at Hoag, we use this system called Epic, which is a very good electronic medical record. And for those of you that kind of log into the portal, you know that you can email with us, you can look at your medication list, you can modify things about your history, you can make appointments. There's all sorts of stuff that goes on your end. On our end, there's a lot that goes on. So on our end, every time we prescribe something, it's kind of letting us know, and sometimes it's we just kind of go, well, we still need to prescribe this, especially if it's going to be a short duration medication. The other thing that's hard to recognize is that prescribing cascade, and that's one that as a physician I'm going to focus on, because it really is a thing. Who's causing this problem? Is this a medical problem, or is this a polypharmacy problem? And so those are good questions there. And then the last part here, medical culture, clinical inertia. So we tend to, as doctors, nurses, healthcare providers, PAs, nurse practitioners, we tend to really want to help. That's our thing. And so we don't want to just say, hey, we'll see you later. Things will just get better. We want to proactively do something. So there is a culture of doing things. Let's order this. Let's put you on this. Let's see what this does. And so we do need to make sure that we have clear, valid indications for everything that we're doing. There's a whole kind of thing called evidence-based medicine, which helps us make those decisions. And that's an evolving thing, although it's a practice. And the thing I love about medicine is it's science, but it's also psychology and humanity and everything all wrapped into one. And it's an amazing job to do. But that sometimes, some people need to be prescribed something and those sorts of things. And then the other one that I kind of put in that category is this thing called legacy prescribing. And that's a little bit of what I talked earlier about, the person that comes in, I say, hey, why are you taking this? And their response is, I have no idea. Somebody prescribed it for me, and we don't know. And then if I decide to continue prescribing that, that's what's referred to as legacy prescribing. That I'm just just going, okay, well, I guess we'll continue it. And we probably shouldn't be doing that. We should be really thinking about that differently. Okay, so back to the larger picture type of thing. So what I want all of you to walk away here with this deprescribing is first know that this is not it's not giving up on care or withdrawing care. It's really trying to streamline your care and make it more efficient. And prescribing is part of good medical practice. The deprescribing is part of good medical practice. This is a thing that all of us should be engaged in. And I put here, it helps us get back to those 5 principles, which is true. Which I think is the most important thing to our overall health, our overall sense of well-being. I put in here, know what medications you take. It really, really is important that you, as a patient, have that information, that you know what you're taking. And if you don't, you need to, or you're not able to manage that, you need to have a designated person that can help you with that. And there's a thing called an advanced directive, which we can help you get one through the office, which designates a person that would be your healthcare decision maker. And that person you should have a conversation with and say, hey, these are my medications and this is when I take them. But knowing your own medications is hugely important, and it kind of goes right into that other one. Communicate with your loved ones, and by loved ones, really that advanced directive decision maker it should be a loved one. You know, I was my father's advanced directive decision maker during the last few years of his life, and it really was an honor, you know, to be in that position and to be able to, you know, kind of like, you know, pay him back on the flip side, you know, from what he did for me growing up, you know. So so just make sure you communicate with those people. None of it's secret, you know, like, and even with the sort of things of like, you know, what you want to do in terms of life-sustaining care, CPR, it's not, don't make it a secret, you know, make it known to everyone. And same thing with your medications. Okay, so just the recap here, and I think we're right, perfect timing, I hope. So we're going to all create our own personal blue zone. So that is my big thing with taking care of anyone. And actually all of this information is not just for those that are over the age of 65, but it's for everyone. That this really, and back to Seneca and Cicero, they really were saying that in order to have a great fulfilling life here, we got to do it here too, so that the whole way along we're doing it. And so that's what we're doing here, is we're creating this sort of bubble of health around us. And we want to focus on another typo here. We want to focus on only the medications we need. So we don't want to be taking things that are not needed. We want to focus on non-medication approaches to our medical problems. You know, so that's physical therapy, it's exercise, it's nutrition. You know, all of the things that can help us with these medical issues that are not pills. And again, the last point, I know I've harped on it several times here, but it's not stopping care, that this is actually being proactive about your safety and your medication needs. And it's a really important topic that I hope we're going to hear more and more about as time goes on. And then questions. Okay, so guys, thank you very much. I don't think that there's any questions right now, so I just left here a few resources for you guys that, you know, where I get a lot of my information on these things from. And it was a pleasure to be able to come out and talk to all of you. And just remember, I'm Dr. Kurt Armstrong, and my group is Newport Family Medicine. We're here on the Superior campus of Hoag. My group has 5 physicians. We have 4 physician assistants, so we're you know, a big group here, and we're working with Hoag every single day, and we're all Hoag physicians. So thank you very much.